Greetings, attendees. We're excited to offer this, I would say, milestone opportunity, showcasing a strong partnership between the country of Finland and the United States, here primarily in West Baltimore and Maryland. So I'm really fortunate to be in a company with Dr. Maria Eriksson from the University of Helsinki, from Dr. Alan Lyles from the University of Baltimore, and Dr. Daniel Mansour from the University of Maryland, Baltimore. Our topic this morning, or topic today rather, is going to be on medication safety in older adults, a global perspective. And with that, Dr. Eriksson, would you mind introducing yourself?
Okay, thank you, Dr. Brandt. And thank you for inviting me to be part of your session. And it's been great to work with you on this important topic. And I would also thank Professor Alan Lyles, who have been making this cooperation possible during the years, and also Dr. Daniel Mansour, who has been a great honor to also work with you and learn to know you during this project. So I come from Finland, capital area in Helsinki, University of Helsinki, and I have a research team there, and we have quite close cooperation with the hospital, university hospital, but also with the community pharmacy and primary care. And our focus has been medication safety, but we have been now moving towards the older patients and older people's medications and patient safety, because it seems to be the population group of highest risk of patient safety incidents. So that is my background, like briefly, and looking forward to this session.
Fantastic, thank you. And Professor Lyles, can you give us a little bit of introduction on your background and working with Finland?
Yes, I should say at the beginning that I'm a graduate of the University of Maryland School of Pharmacy. After pharmacy school, I completed an MPH and an SCD at Johns Hopkins. My doctorate was in health policy and management. Lifelong interest in international affairs, which became international matters relating to pharmaceuticals. And what I would emphasize briefly is the role that having a vision for what you want to make contributions about, and then seizing serendipitous opportunities, random things that arise. The experience I have in Finland has encompassed being an acting chair of pharmacoeconomics for several months, some 10 or 15 years ago, a couple of short-term Fulbright programs, and ongoing regular lectures, research projects, working with my colleague, Dr. Eriksson and others there. This all came about because I participated in a workshop in Kuopio in 2000. And then in 2005, randomly, Maria was stopping in Baltimore to visit an old friend from USP, and he was a mutual friend, so he invited me. I spoke with her about the opportunity of this Fulbright program. She said, well, I'm busy, but I'll catch up with you. Over time, that's how this has flourished, and it was entirely random. I'm delighted that it has taken this much substance now. And with you, Nikki, the ability to connect you with Maria came about because I first met you when you were a student in the MBA program and you took a course with me. Mm-hmm. So it's this idea of opportunity presents itself, but as Pasteur says, if you don't have the prepared mind, then it's not opportunity. Thank you.
Oh, fantastic. Thank you, Professor Lyles. And you're absolutely right about random and opportunity. And I'd like to have Dr. Mansour introduce himself as well.
Yeah, sure. I graduated University of Maryland as well back in 2006. I went on for residency in geriatrics at the VA in Minnesota. I'm happy to be here. Currently, I'm the interprofessional clinical coordinator of the Peter Lamy Center. I'm also honored to have had Dr. Brandt as my professor at one point in time and my teacher. So happy to work with you guys and now looking forward to
Fantastic. Well, this is, again, quite an honor. I wanted to set the stage with giving a little bit of background about, as many of you mentioned, your relationship with the University of Maryland, but I also wanted to speak a little bit about our program here, and then I will turn it over to Dr. Eriksson to talk about the work that she's doing in Finland. But we'll kind of give a little bit of history for those of you watching and maybe not as familiar with the University of Maryland Lamy Center. So the University of Maryland Lamy Center is, I like to say, 41 years young in its program existence. And this center is housed within a school of pharmacy. And as Dr. Mansour and myself will mention, we're both practicing pharmacists. And its focus has been to improve medication use and safety in older adults, and really that connection with education, practice, and policy, as well as research to further the fields, both within pharmacy, but also within our interprofessional training. And that really has been the mission of the center for over 40 years. And I think it really speaks to its legacy and success. And talking about legacy and success, here at the University of Maryland, Baltimore campus, there was a launching of a Center for Global Engagement program called the Global Fellows program that started in 2019. And actually, Dr. Mansour and I were part of that fellowship opportunity. And it really bore out of a relationship in West Baltimore, which focused on a community course, which is a hybrid course of both didactic learning, but community placement. And during this partnership, we worked with Dr. Lyles and Dr. Eriksson from the Clinical Pharmacy Group, Division of Pharmacology and Pharmacotherapy at the University of Helsinki. And some of their students joined us 2019 to 2020. And I just need to make mention that this program is actually an ongoing relationship as part of a bigger umbrella within the University of Maryland, Geriatrics and Gerontology. We currently have funding with our partnership with Johns Hopkins Medicine as part of our geriatric workforce program. We're also in partnership with our Geriatrics and Gerontology Education and Research here at the University of Maryland, and all of these are hyperlinked within the slides. And this is part of a bigger age-friendly university global network that the university here launched in 2019 as well, and has been going on for a year. And I just want to do a large thank you to our partners as part of this Aging in Place course. And those would be, as you see on the screen, Dr. Mansour, Dr. Kelly Duran from the School of Nursing, and Dr. Barb Resnick from the School of Nursing, Dr. Diane Martin with the GGARE program, who's the new director, and then Dr. Tyrone Roper. Mr. Tyrone Roper is our Community Engagement Center Director. And we've been very fortunate to have numerous students throughout the years. And briefly, I'm not sure, Dr. Mansour, if you would like to take a moment just to share these two slides regarding our Aging in Place program, and really captures the humanistic angle of the work that we're doing.
Sure. So the Interprofessional Care in Geriatrics Aging in Place was developed from a long history of interprofessional work in geriatrics. Initially, it has focused on a single intermittent program here and there, in which students and faculty from multiple disciplines come together to use case-based approaches for teaching. So back in 2015, the experience was born. And faculty and students from many disciplines, social work, namely nursing and pharmacy, came together as the first cohort of students willing to work together with older adults in the community, and formed, we call it the first class, but we call it back then an experience. All of the students in the picture, in this picture, have graduated already and went on to higher studies. We're so proud of them. And went on to higher trainings as well. From the left to the right, the social work student, there's a medical student, We have another medical student and the pharmacy student to the very far right. Next slide, please. So just to give you a little background, the Aging in Place program is we call it SIP 621. It has a course number. It's a 3-credit graduate level course that went through several stages in terms of vertical and horizontal growth. It presents a unique interprofessional opportunity that expands beyond just the one-day interprofessional education activity, typically required by schools, on all schools on campus and programs. Actually, programs across the country even today. So basically what we do every Thursday afternoon, the IPE students would partner with older adults to manage multiple chronic illnesses and psychosocial challenges. Students from various UMB professional schools came to learn with, from, and about each other. It's about interprofessional work, right? And also about the interprofessional care of older adults. Students came to us from schools of dentistry, dental hygiene, the Doctor of Nursing Practice, Physician Assistant Program, School of Medicine, School of Nursing, namely RN to BSN programs, pharmacy, physical therapy, social work, and audiology most recently. This course fulfilled a particular curricular need that is unique to a particular healthcare discipline. For instance, the course provided field placement for the student from social work, service learning for the student from medicine, leadership placement for the students from the DNP program, and as an elective for others, such as with the PharmD program. This experience includes a clinical focus with hands-on work with older neighbors. You can see from the picture one of our nursing students giving a hug, just giving that personal perspective to one of the neighbors, and this was not uncommon actually throughout the course. The overarching goal was, anyway, is to help these neighbors age in the community. So with that, I'll give back the microphone to Dr. Brand.
Thank you, Dr. Mansour. And at this time, I think this is a wonderful segue to talk about what's happening globally in aging. And the overarching intent of this lecture is to focus on the medication safety angle, but what we've learned from working with our communities, medications are just one of the many aspects that we can help kind of navigate resources and learning and shared learning together when caring for older adults to help them age in place. So with that, Dr. Eriksson, I'm going to forward the slides for you as we talk a little bit about what's happening from a global aging perspective and medication safety.
Okay, thank you, Dr. Brandt and Dr. Mansour. It's a really growing importance. We have everywhere in the world, people are aging, and there's some statistics that I think Dr. Brandt has put together here about this situation with aging people and populations. And you can see that so that there, in many countries, the situation is becoming to that point that there will be more older people than there are like young people or children. And Finland is one of those countries. I think we have one of the fastest aging populations in the world. So we are in a way facing that challenge now in our society, so that how we can find out resources, healthcare providers who are also specialized in geriatrics. I think that is one problem that we are facing, that we don't have enough people who are trained to take care of these older people, but then also how to organize facilities for them. And the policies in Finland has been that we want those older people stay home as long as possible, so that organize support for them at home, so that there will be like this nursing aid available, and other that kind of aid, assistance that they need to survive at home. But still, it is a problem when they get to that phase that they can't manage at home, and then there will be assisted living facilities, and that is what we want to have more, so that it will be more like quality of life is important, so that how they can stay in a place that they can get together and still be socially connected in this older age. And as you know, when people age, there will be more diseases, and then maybe the likelihood of having medicines also grow. So then it can become very complicated, the medications. And that is one challenge. So that how do we have that kind of nurses, pharmacists, physicians who are that much specialized in geriatric pharmacotherapy? And we don't have, at least in Finland at the moment. And then we are trying to find how we can make that kind of learning opportunities that everyone who is working in the field, so with the patients, could reach these new competencies. And this course that we have been able to participate with our students last spring, it has been eye-opening for us to find new ways that we can start teaching each other and learning from each other. And that is a very nice principle that we have learned during this cooperation so far. And now we are in the phase that we can start applying it more now also in Finland. And I hope that there will be more countries, and I'm sure that there will be more countries to join, and more, as you said, that also in the States, that it is growing, those people who are involved, and there's really need for that.
Absolutely.
Okay, there's some. Pardon?
No,
Yeah.
Absolutely, Maria, in terms of the growing partnerships, which gets to the global world, right, of medication safety and potential harm.
Yes, yeah. And actually it was some years ago, WHO, World Health Organization, they also identified medication safety as a very important part of patient safety. And I don't know if you are familiar with the WHO's patient safety program. It has been running now about 15 years. And I really highly recommend that you will go to the website and find the resources, what they have there, because there's a lot of practical resources, even for training healthcare providers on patient medication safety, but also practical tools that you can apply in your clinical practice. So that the first program they had was focused on hand hygiene, and then the second one to surgery, so that how to make surgery more safe. And then the third one is now focusing on medication safety, like medication without harm. And you can find the link here on this slide to learn more about the program. And here are the 4 points that the Global Patient Safety Challenge is focusing. And it has been like a large stakeholder network that has been creating this program, so that it is meeting the needs of like developing countries, but also low and middle income countries. So it's applicable to all kind of circumstances. But it's very important that we will engage our patients more in the medicine use and in their care. So we, at least in Finland, we are not very good at that. And actually now it has becoming more and more priority in our health policies and medicines policies, for example, by our medicines agency. And then the evaluation of medicines, that is one part. And here is a condensation of this program and what are the key points there, so that the program is focusing on high-risk situations, polypharmacy, and transitions of care. And I think this is in every country the same kind of problems that occur with them. And we know about these high-risk medicines, and it's important that we learn to identify those and how to manage them. But polypharmacy, if people use many medicines at the same time, how we can make sure that it is safe cocktail for them. And then also the transitions of care, so that how we can have the medications lists updated and other things that are related to that. And this digitalization of healthcare, it might be one part of the solution in that. But so this is also a very good figure to identify what you should do in your own healthcare organization or in your own practice to make it medicine use safer. Okay, then we can go on.
So this is
So-
just kind of posing the question, which I think sets the stage for kind of the next conversation is, when you think of medication safety in older adults, what questions or concerns do you have? And I think there's been a long-standing concern of not enough research, or maybe focused research, or, workflow policies and programs that are sustainable. And even as we talk about the training, I know we're focusing on educating others about this very important topic, but there's a lot more work, as you mentioned, of co-designing programs that really matter to older adults too, and getting them more engaged in that future programs on med safety. So with that, I'll turn this back over to you, Maria, but those are just some questions I think about how can we do it better, and hopefully we can learn more from each other here.
Yeah, great. And here are some that kind of figures that we have been using with our students a lot, and also practitioners in their training. I think they are very helpful to identify what that kind of challenges that we have and risks in our own medication use processes, what we should focus on. And this first figure, it's describing what kind of inappropriate use can occur with medications, so that there's the green one is about the appropriate use, and then there's these different ways medicines can be used inappropriately. It can be underuse, it can be overuse, then as many other ways. But if we don't, in a way, have that understanding, but it would be very difficult for us to identify what is happening with the medications if we meet our patients and then discussing about the medicine use, how is everything going with the medications. I think that is a map that helps us to make this kind of identification of problems, and then we need to know how to solve them. Maybe then we can go to another one that we have been using a lot, so that the Swiss cheese model. Yeah, this is something that we're saying that any pharmacy student, no pharmacy student can graduate from our pharmacy school nowadays without understanding the Swiss cheese model. And it is one classic. There's different ways of illustrating risk management, but this is one that we have been using a lot, and it has been also background for WHO's programs and other international programs on patient safety. And it gives you the idea that if something goes wrong, for example, in medication use process, for example, a physician makes a wrong diagnosis or prescribes a wrong medicine, and then if there won't be any that kind of point of care, or for example, there won't be a pharmacist double checking or anyone else noticing that this is not right medicine to the right person, so that then it can go to the patient, so the patient will take that wrong medicine and then it can harm the patient. So this has been a very excellent way of identifying these risk situations and risk patients, and how we can then make systemic defenses. So how we can make that kind of barriers there that won't happen. It can be, for example, pharmacist working with the physician, or for example, also counseling patients, so that giving advice how to use the medicine. It would be one way to prevent this kind of errors to happen. Okay, so that is, and this picture is from Finland, and this is reminding that we have a challenge here with patient and medication safety in nursing homes. And what I have now been reading news from different parts of the world, it seems that this COVID, for example, it's been raising this, that they are very vulnerable, those old people who live in nursing homes. But we have also now found out that there's a lot of problems that are posing them the patient safety risks, and medications is one part of that. And we have now community-based projects, like what Professor Lyles mentioned about this Keusote, or this primary, this So it is the place where we are now having researcher nursing homes observing and also using the medication error reports to find out what are the risks. If you think about the Swiss cheese, where are these holes in the cheese? And then how we can make these systemic defenses there. And we are also working with medical authority to make sure that maybe we will have that kind of checklist that is obligatory checklist in the future that they need to follow to make the medicine use safer.
Yeah, those are really great points, Maria, in terms of what we've learned during COVID. And I know here within the United States, the vulnerability of individuals who reside within nursing homes are not just older, but often with multiple comorbidities and very much at risk and taking multiple medications. And as we did a little bit of work early on in the pandemic with the simplifying medication regimens to really reevaluate that. But I think it's a really enduring work needs to be done, because I've heard many stories and have my own experiences of individuals being put on more medications, and especially psychoactive medications or psychotropic medications, antipsychotics, antidepressants, to manage some of the behaviors and challenges, especially in those with underlying cognitive disorders or Alzheimer's disease. So yeah, it's a lot of work to continue to be done, and I think we've got a lot of shared experiences and opportunities to collaborate there.
Yes, yeah.
Leads
and it
to
sounds like a story from Finland, what you were telling. So yeah, really.
Absolutely. And we'll look forward to exploring that a little bit more. We're currently doing some work here with our national data sets on medication use in nursing homes. And I think this leads to some great discussion points. And I know we don't have a plethora of time to talk about all of these, but I think, when we think about medication safety, it continues to be access to healthcare. We again have seen during this pandemic concerns and disparity and access and social determinants and certain groups being at greater risk. And so, but despite seeing potential negative, we've also seen potential growth and opportunities of improving access through work with telehealth and also delivering medications to people's homes where they might not have done those programs before. So I think there's definitely weighing the balance of things we've learned and things we can do better for the future. But any thoughts on access to healthcare within Finland? Just accessing healthcare in Finland. Is that a concern that you've been challenged with as well?
Yes, yeah, it is a challenge. And now COVID is making it even harder at the moment, but also for older people who don't manage at home anymore. So it's not easy to find, for example, nursing home for them to place, so that we are running out of resources in that way.
Yeah, no, we're same here, especially in terms of being conscientious of the COVID pandemic rates and potentially limiting the number of residents who are residing in long-term care and other sites, which gets at, unfortunately, we've seen a decrease in potentially of services to older adults because of some of the budget implications and resources on a state and national level. So to maintain aging in place. But I know I've been personally very impressed by what's happened in Finland in terms of providing services to help, as you mentioned at the beginning, helping older adults stay at home as long as possible. Would you want to speak to that just a little bit more, your experience with that?
Yeah, so it's been now like that kind of political will for quite a long time. And actually it was 2013 when we had a law on old elderly care. It was the first time that they put together all these principles that how the quality of care should be ensured for older people. And actually, we have been very lucky to have a close cooperation with Professor Sirkka-Liisa Kivelä, who has been the person who fought for this law to become true. And it has been also focusing on these medication safety risks, but also competencies of people who are working with older people, and also how many people or how many nurses, for example, should be in those facilities to take care of the older people there. So and we have public health healthcare system. Maybe that is the quite big difference between our countries. So that we have a public health law that says that everyone who lives in Finland have a public insurance and the same equal coverage to services and, for example, medications, so that it is the same for all. And in a way that ensures that regardless of your income or social status, you will be covered by this social insurance. And I think it's been very good, and I hope that it will continue that way, so that we can have that kind of equality in healthcare.
Thank you for sharing that. And I think that's a nice segue in terms of looking at medication safety and comprehensive medication reviews to further the training opportunities. So I'll turn us to the next slide.
Yeah, so as I'm a pharmacist, as my background, and we have had quite traditional pharmacy education, and pharmacists have not been so much involved in patient care as in the States. So you have been pioneers in that. And what we have learned is a lot about the medication reviews and clinical pharmacist work from your experience. And Professor Lais has been one of those who have been supporting us a lot to go to this direction. And it was 15 years ago when we started this kind of accreditation training for pharmacists to have more skills in comprehensive medication reviews. And today it is part of the normal undergraduate training for our pharmacists. And this is this figure is by Saija Leikola, who was one of the pioneers to make a PhD in this area. And I thought that to share this with you, because it's been a very nice map that we have been using with our students. It is putting together what do you need to evaluate of the situation of the patient, so that it's not only the pharmacology, but it is also what are the diseases they have, how many medicines they are taking, if those medicines are okay for their condition, and also what the aging adds to this situation. And for example, kidney function and adherence is one part. So how they are able to take the medicines. If they are alone, can they take their eye drops, or if there are any other that kind of problems with taking the medicines. And then there's also like the drug costs. I think it's also a barrier here, as more and more people who, if they have a low pension, so that they need to decide this month if I will buy my medicines or if I want to buy food, and how to make sure that that won't be a barrier for people to take the medicines they need. But this all needs to be considered when you discuss about the medication of the individuals and how they are managing.
Absolutely. That's a great illustration of that. I love the comprehensive nature and the quadrants. It makes it very clear. So, and I think just to speak to some of the work that has been happening over in Europe as well is wonderful.
Yeah, I thought just like briefly, I thought if you are interested, you can find some information about these medication review practices, how they are evolving in Europe. And there's now a big boom in Europe in many countries that they are starting to have more competencies in medication reviews, also in collaboration, so that pharmacists are involved and nurses are involved. And this, if you want, you can read more here what is happening. And this is the same kind of inventory from Finland. It was conducted. The data is from 2015, but just for you, if you are interested. Yeah. Then we can move on. And we also were able to conduct intervention study in one of our communities close to Helsinki. This was funded by our social insurance institution, like public insurance company. And we were developing collaborative medication management model between home care and community pharmacies, because community pharmacies are a resource that could be better used in older patients' medications and risk management, prospective risk management there. And so it's been underused, and then we now wanted to make a closer cooperation between all these partners involved. And this we have two papers. The first one was describing this collaboration model, and the second one was describing the outcomes, what we were achieved with the model. And I think the lesson learned was that it is possible, for example, to reduce this psychotropic use. I think that was we were focusing on this drug-related risks and problems and how they can be reduced. But what we also learned that physicians are not very willing to cooperate. And there's this very strong hierarchy still in our this community-based care. And I don't know how we can break that hierarchy. So that's something we are working on at the moment, so that how we can put all these people work together, and also so that they will notice the patients there, so that also involve the patients.
Absolutely, great points. And I think what we've learned in our history here is it's really if we can get them training together and provide clinical settings in which they work together and they're valued equally in that treatment team and approach, and they can communicate effectively, I think that's really key. So, and I know you talk a little bit more about some of the other literature too with medication burden and safety from a patient's perspective.
So this is also something we found from the literature. Actually, this paper is from University of Sydney. We have very good colleagues there. The excellent work that they have been publishing a lot, like Professor Timothy Chen. Actually, he was one of those who came to Finland also to train our first pharmacists in medication review competencies. And this is a very interesting model they developed about medication-related burden and patients' lived experience with medicines, because we talk a lot about adherence and compliance and why people don't take their medicines as we expect them to take. And I think this is giving you a new approaches to that. And we are now working on this to maybe try to find some measures or somehow start using this also with our students and maybe with medicine users, so that so to be more aware of all these aspects that are influencing people's behavior with their medication. So it's not straightforward, because nowadays we just trust that if we'll have a reminder in cell phone or that will solve the problem. But I think it's not that easy. We need to go deeper to this process, and this is very helpful tool. So I hope that you will have time to read that one and think if it will be helpful also for you.
Mm-hmm.
Okay, so this is the model that they developed, and it is based on, it's like a systematic review, so that they searched international literature that is the qualitative perspective to medicine taking, like patient's own perspective. And then they made a meta-synthesis of that information and created this contextual model. So I think it's very interesting way to create this kind of information. So it's not only one study, but like a bunch of studies, and then they made this kind of conclusion. And then here's one recent PhD dissertation from our research team. And this is about medicines information. So it is very important for us. And what I can tell from my background, one of those crucial things that has happened in my career was that when I finished my PhD, I was so lucky that I had 1 year postdoctoral training at the United States Pharmacopoeia in Rockville, Maryland. And at that time, I was working on a research group on medicines information and guidelines on medicines information. And I think this has roots, this thesis at that time, but it is also describing the evolution from paper-based information to cyber. So, and we are now going very fast to that direction. And we are now also researching how older people can manage with this digital leap that we are taking, and how they can be able to reach the information they need about their medicines. But this is online, that resource or this thesis.
Fantastic. That's amazing.
But yeah, I think, it's time for me to thank you for this opportunity to have this session. And this is part of our team just 5 years ago when this picture was taken, and you can recognize one person from Baltimore there.
Mhm.
And it was also, I think we can thank Professor Alan Lice about that, Dr. Kenneth Shermock from Johns Hopkins came to Finland for 6 weeks and was working with our team, and this picture was taken from that time. And many of these people that I was mentioning in those my slides and what we have been doing are sitting there, so that now they are PhDs and contributing in different positions in healthcare to patient care, and especially in this older people's medication safety. So thank you very much for your attention, and looking forward to continue our cooperation.
Fantastic. That was such a great overview of the work that you're doing in Finland, but beyond when it comes to medication safety and use and the patient's perspective. What I've treasured working with you and Dr. Lyles is the framework and approaches and the structure to really consistently evaluate the importance of this work, and then it can be larger and replicated in other countries and other areas around the globe. And I think that's really important, because when I think about my global vision for the future, is there's been a lot of wonderful work done, and I think we just need to be mindful and maybe a little bit more inclusive of looking at others' work, and how can we look within our own area, with whether it's a country, it's a state, globally, to see how it can improve. And really applaud you for setting the stage with the World Health Organization's, challenge for all of us, because it's really not just a challenge of education, but it's a challenge of how do we break down barriers and work more cohesively together. So really excited to be a part of this. And again, I can't thank you enough for the opportunity to lecture together virtually in this space, but also to collaborate in really improving the care of older adults.
My pleasure. Thank you for you making this possible.
Absolutely.
Highly appreciate that.
Well, and a thank you to Dr. Mansour for joining us. I also thank you to Dr. Lyles and others who've supported this work. And I just want to say, as we're increasing competencies for our learners out there, there are both national and international resources for student learners that I think just to be mindful of as we train to share our work and share our resources. So I just wanted to share this with the students as well. So at this time, I'll end the lecture, and again, thank everyone for their participation and support. And